Good morning, everyone. It's a bright sunny morning, so we'll have an exciting session on polymorphic VT, and this will be presented by faculties from the prestigious Sion Hospital from Bombay, and we have very experienced faculties which will be introduced. Before that, I'll just hand over the mic to Yes sir, who is working since a long time to the Sion Hospital as an electrophysiologist, and he has been training many fellows and PGTs from there and inspiring everyone to do a good understanding of ECG and EP. Yes, sir. It's over to you, sir.
Thank you, Deva. Good morning, everyone. Uh, I thank Jaskaran, Anis, and Rajiv to be here, and of course, Deba for hosting this, and the IHRS for giving us an opportunity to present this session. Now, this is mainly going to be focused to the cardiology students, both from the DM and DNB stream. So it will not have intracardiac EGMs. It will only discuss the clinical scenarios. And I thought polymorphic VT has a wide spectrum. So it is something where understanding for the students is crucial. And the first talk will be by Abhinav, who is our associate professor he's both at Sion and KEM. He's now an experienced electrophysiologist. So, Deba, is the introduction to be done by me or by Jaskaran? What is the format?
Both are okay, sir. I think you can introduce because Jaskaran might be knowing very well Abhinav. So you can introduce Abhinav.
Okay, so Abhinav has been quite prolific also academically. You can see multiple publications of his with multiple groups, and he's a good thinker and a good teacher. So to give us broad spectrum of polymorphic VT and focusing on what is common in clinical practice, I now ask Abhinav to start his talk. I feel during the course of this debate, during the course of this webinar, sometimes if there is a question in the audience or amongst the moderators, at a particular slide, they may just ask the question right away, so that we don't have to go back to that slide later.
Sure, sir. So you can be this thing switching point, sir. You can have a watch on that, and obviously Anish sir and Jaskaran is there, so you can stop anytime so that Abhinav can stop and we can discuss and then proceed. We have enough time because we don't have a time constraint much because as per the schedule we are finishing at 11:15, but we can stretch up to 11:30 comfortably.
Okay, Abhinav, over to you.
Thank you, sir.
Thank you for the kind introduction, sir. So I'll just start sharing my slides. Are the slides visible? And
yes, they are visible. Yes, you can go to the full screen mode.
Yeah. So thank you, IHRS, for providing me for this opportunity. Thank you, Veera sir and Raja sir. And thank you, Lokhandwala sir, for the guidance and support during the preparation of this talk. So my talk is approach to polymorphic VT, and we'll start it very simple. So ventricular tachycardia can broadly be divided into three patterns. Monomorphic VT, in which you will get one single morphology on the ECG. Then pleomorphic VT, when the QRS complex morphology is going to be identical for a few beats, and this will be followed by a different QRS morphology for a few beats. And lastly, we have polymorphic VT, which is a malignant ventricular arrhythmia with a changing QRS pattern from beat to beat. So what we'll do in this webinar is we'll try to develop a systematic approach to recognize the etiology of the polymorphic VT, so that when you are faced with these patients, you develop a systematic approach into how to treat these patients. Now, a polymorphic VT may deteriorate into ventricular fibrillation, or it may terminate spontaneously. Now, when you encounter a patient with a polymorphic VT, the first thing that you have to do is to find out what the etiology of polymorphic VT is. Now, this is important because the treatment is going to differ based on what the etiology of polymorphic VT is. However, before uh, before we go into etiology of the polymorphic VT, the first thing that you should do is to exclude the mimics because uh, uh, because the treatment is going to change. So when we are talking about the mimics, you have two main categories. One is artifact and the other is atrial arrhythmia with ventricular pre-excitation, which may give the appearance of polymorphic VT. So this was a patient, 45-year-old gentleman, came with PVC on his ECG and was implanted a halter. Now, on this halter, we had the appearance of what looks like a polymorphic VT. But if you look at the QRS complexes in lead 2, you can see that these sharp QRS complexes are marching throughout the alleged VT. Also, if you compare with the termination of VT that we saw on the third slide, you will realize that the polymorphic VT is going to be terminated followed by a pause, and here the polymorphic supposed VT merges with the next QRS. So this is a motion artifact. This can also occur if the lead on the chest comes loose, and all we had to do for this patient was to reassure the patient. The other differential for a polymorphic VT is a pre-excited AFib. Now, the pre-excited AFib will give rise to a will give rise to arrhythmia that is going to be fast, broad, and irregular. Now, here the irregularity is going to be profound. If the refractory period of the pathway is less, this can degenerate into polymorphic VT. Now, the important thing to realize here is the treatment in this case is ablation rather than giving the patient an ICD. So once we have excluded the mimics, we will come to the left part of the algorithm. This is from Wiskin's approach to polymorphic tachycardia, so you can go and read it. Now here in the left part, you basically do this as a three-step approach and you ask yourself these three questions. So the first question is, does this patient have a prolonged QT interval on the ECG? This can be congenital or it may be acquired. The second question is, does this patient have a organic heart disease, which may be secondary to ischemia or maybe one of the genetic channelopathies? And the third question that you ask is if this VT was induced by exercise. Now, the genetic channelopathies, that is Brugada, short QT, idiopathic VF, and malignant early repolarization, this we have already discussed uh, in the IHRS lecture itself, which we had taken previously. And CPVT will be discussed further with case example during the later part of the seminar. So what I'll be concentrating throughout is these three things: long QT, ischemia, and the outflow tract VT. So we'll come to the ischemic polymorphic VT. Now, this is the patient that you are going to be most commonly going to encounter in your clinical setting. Now, coronary artery disease, which may be due to acute ischemia or in the setting of acute myocardial infarction, is the most common setting. And this is broadly divided into two groups. One is ischemic VT and other is when the ischemia is relieved. However, during the recovery phase, let's say between 3 to 11 days of the acute ischemia, you may have something which is called as Purkinje related polymorphic VT. So we will discuss each of these with examples. Now, this was a 50-year-old gentleman, known hypertensive diabetic, came with anginal chest pain of 2 hours. Now, as you can see here, you have a ST segment elevation, RBPB, and you have what is seen here as a ischemic polymorphic VT. Now, what you see on the ECG here is ST segment elevation along with short coupled ventricular extrasystole. This can occur in the setting of ST elevation myocardial infarction, may also occur with coronary spasm. Uh, this may also occur in patients who have a pre-existing coronary artery disease, and if you subject them to TMT, here you can see ST segment elevation in the inferior leads, and this degenerates into polymorphic VT followed by VS. Now, polymorphic VT can also occur during the recovery phase of ischemia. This will usually have a Purkinje trigger. However, here you can see that there is no ST segment elevation on the ECG leads. These VTs are typically sensitive to quinidine and will respond excellently to it. To summarize broadly, the ischemic polymorphic VT, they have an incidence of around 2%. This comes from the study by Wilde et al., in which they studied a patient group of around 411 patients over a period of 3 years. However, many authors believe that this is likely an underrepresentation because a lot of ischemic polymorphic VT may present as the initial sudden cardiac death event, and the mechanism of onset in these patients may be sudden or maybe non-sudden, in which you may see PVC or PVC couplets on the Holter or ECG monitor for a lot of days, followed by degeneration into polymorphic VT. The non-sudden is more common. This is around 64 to 65% compared to sudden, which is around 30%. And the treatment here in the setting of ischemia is going to be urgent revascularization. While you are planning for revascularization, the beta blocker or amiodarone therapy can be given. Now we come to the next most common cause of polymorphic VT. This occurs in the setting of a long QT interval, which may be congenital. Now, this we have discussed already in the last seminar, so we'll go to the acquired part, where this may be due to a multitude of factors. For example, drug-induced drugs that cause QT prolongation. Then bradycardia can cause prolongation of the action potential and cause long QT. Post-infarction like Takotsubo, and metabolic abnormalities or electrolyte disorders like hypokalemia, hypomagnesemia may also give rise to a long QT interval. Now, this is called as TDP because there is a progressive change in morphology, amplitude, and polarity of the QRS complex, whose peaks twist around a isoelectric baseline. Diagnosis for congenital long QT is with the modified long QT score. When if you have a score more than 3, then it is considered as long QT. When these patients present with polymorphic VT, they will typically have a prolonged QT, that is a corrected QT which is more than 500 milliseconds, and this has a characteristic mode of onset which may be either tachycardia dependent or bradycardia dependent. In the tachycardia dependent, which is associated with long QT1, there will be, when there is a tachycardia, you can see here that the T wave morphology is changing. Now, this represent repolarization abnormalities, and this can be a precursor to the TDP. The other thing is bradycardia dependent TDP initiation. Now, here when you have bradycardia, there is a prolongation of action potential. This normally does not give rise to anything on the surface ECG. However, when this early after depolarization reaches the threshold potential, it will give rise to a PVC on the surface ECG, and this can give rise to a long short sequence giving rise to a TDP. Uh, Other group of disorders which is not discussed in the Wiskins paper, but you may see commonly in your clinical practice, is a group of disorders which may have myocarditis, like tuberculosis and sarcoid, which we see more often in our country. Also, arrhythmogenic cardiomyopathy and hypertrophic cardiomyopathy may present as a polymorphic VT. Now we come to the last part of the Wiskin's algorithm, which is a PVC which may give rise to a polymorphic ventricular tachycardia. Now, this may be a short coupled PVC which arises from the Purkinje, where the coupling interval is less than 300 milliseconds, and this may be secondary to a idiopathic RVOT-VT. Now, RVOT-VT is generally considered as benign. However, it may sometimes give rise to a polymorphic VT. These will have intermediate values. So these are not very short coupled, that is not less than 300. However, they will have an intermediate value of, let's say, 340 plus minus 30 milliseconds. The most common thing in a ICU that you are going to see is a polymorphic VT, which is multifactorial. Now, these may be drug-induced or drug-induced QT prolongation that may give rise to a polymorphic VT. Azithromycin may give rise to a polymorphic VT. However, in these cases, the QT may not be prolonged. Also, these may be multifactorial. For example, a patient with myocarditis in heart failure, you give him Lasix, the patient goes into hypokalemia, and this contributes as a whole to the QT prolongation and the polymorphic VT. So let's come to the last slide. If you remember nothing of the entire lecture, just remember these 3 points. The first thing is you ascertain the diagnosis. You do not want to be putting an ICD for a patient whose Holter just showed an artifact. So exclude mimics, ascertain the diagnosis, then rule out ischemia, because this is the most important and the most prevalent cause. The other thing is you rule out prolonged QT. This may be secondary to multiple factors, and the treatment for a polymorphic VT is going to be secondary to the underlying etiology. Thank you.
Excellent talk, Dr. Abhinav. So, excellent and more importantly, very simplified talk. So,
Thank
just to summarize what you told in the last slide, the first thing you need to rule out is artifact. Once you've ruled out artifact, and you should rule out pre-excited AF. And once you've ruled out these two things, you know you're dealing with a life-threatening scenario. First thing to rule out is ischemia, which you can rule out using an ECG which comes before ischemia, like ST elevation, or the one that comes after uh, polymorphic VT, that is after defib. So once you've ruled out ischemia as a cause, you are left with very less causes. Like Dr. Abhinav told, the VF can be because of PVC induced, it can be because of long QT, it could be because of electrolyte abnormalities, or in rare scenarios, it may be a structural heart disease related VF. So in this way, you can actually rule out the cause of ischemia rather than simply thinking in terms of do I give an ICD or should I not give an ICD? Thank you, Dr. Nishi.
In a word, nice presentation. I think it's a short summary. I think we're going to discuss about ischemic polymorphic VT in the next session. But basically, when you think of ischemic polymorphic VT in a patient who has an revascularization or after an acute MI, there is a time period which you could, there is a risk period usually it happens within 7 to 10 days of the MI, and they are more prone to develop even immediately after. But if you see something ECG changes in the recovery time, like of QT interval or deep T inversions or T wave alternance or something like, along with LV dysfunction, there is for these patients to develop VT and often polymorph. So some word about what do you think about keeping some of these patients in the ICU for a longer time when they have who is at risk for polymorphic VT post MI? Any comments about that? how do you want to prevent a
So, sir,
polymorphic VT
there
in a
is this study by Wilde et al. In which
Yeah.
they have said that, I mean, this can be divided into sudden and non-sudden. So, sudden are those in which you will not have any warning symptoms beforehand. The non-sudden is the ones in which you have PVC on monitoring. So if you have a patient post-plasty, you are getting PVCs multiple times. These are the patients you may keep in the ICU or on, let's say, where you can monitor the patient and where resuscitation is available. Now, the time period for this is around 3 to 11 days post MI. And these patients are going to be more common in the anterior wall MI compared to the inferior wall MI. Uh, so that is one thing. The other thing is these patients are like pinidin responsive. So like now we have availability of pinidin thanks to the effort of Lokhandwala sir in India also. So that is the drug that you're supposed to give. Ablation is also like one of the things that may be offered in a patient who is not responding to the drugs. So that is one thing. Sudden is going to be a challenge, but the good thing about sudden is it is less compared to the non-sudden one. So if you look at the percentages, 2/3 of the patients are going to be non-sudden one, in which you will have an idea about that this patient may have a polymorphic VT, and you can monitor this patient.
Yeah, thanks. Anyone, Dr. Yash wants to add something to polymorphic VT in the setting of
I think Dr. Bharat Kantharia has a question.
Yeah.
Just can you Anis see that in the chat?
Yeah, about the role of prophylactic antiarrhythmic drugs, right? I mean, in I don't know in what setting, like if it is ischemic heart disease, at the moment, other than beta blockers and close monitoring and correction of possible electrolyte abnormalities, I don't think there is any role for prophylactic antiarrhythmic drugs
I
situation
think
for
probably what
preventing
Dr. Bharat is referring to is in the acute ischemic setting, the prophylactic use of maybe lignocaine or other things. Abhinav, you would like to, because even if that is not his intended question, is often the dilemma. Patient has an acute coronary syndrome. You've either given thrombolytic or antiplatelet heparin or plasty, and there are frequent PVCs. Is there a role of prophylactic drugs, especially lignocaine?
So the only prophylactic drug is a beta blocker that they have mentioned. Lignocaine is no longer recommended for the prophylaxis because they have a like increased risk, so increased mortality risk actually. So,
if I may make a point.
Yeah.
Yeah, the only other drug I would consider if there are frequent PVCs coming in this setting, acute MI, post PCI, post PAMI, would be probably magnesium sulfate for example. Beyond that, I would not think of any NPA.
Yeah, that's what we also feel, like electrolyte abnormalities, magnesium, beta blockers, right? Yeah.
so the other thing, sir, I wanted to point out is in the retrospective study by Wilde et al., they have actually done potassium and magnesium levels. So they have found that like they almost had normal potassium and magnesium levels in all the patients that had polymorphic VT. So I mean, like we do it, but like the studies, they had a magnesium level of in fact 2.1 in their study.
So if there is some, like some anecdotal, information everybody can give. For example, there was one patient who had after MI frequent VPCs, sometimes going to non-sustained VT and polymorphic VT. And at that time, we noticed that the patient had some bradycardia. So in addition to giving antiarrhythmics, which we had to because he was getting polymorphic VT, the VPCs, we tried to ablate it. And then actually he improved after pacing. We maintained the RB pacing at a heart rate more than 75. and then there was no more VT, and then finally he had an ICD. So it's a case by case variation. So sometimes pacing may help, sometimes antiarrhythmics rarely. If the patient has a cardiac arrest or VT, sometimes we give. So yeah, that also can be kept in mind. Yeah. So there was another question about idiopathic VF in a 45-year-old. By anybody would want to take that, because idiopathic VF, no, it doesn't come in the setting of QT prolongation. So whenever there is QT prolongation and torsades, polymorphic VT, it is different from idiopathic VF. So in idiopathic VF, often it is, I think it's there is no cardiac or ECG markers to prevent, to assess the risk, right? I mean, is there any opinion on that? Or, and other than, I mean, there is some evidence for quinidine in idiopathic VF, and then it's ICD. Is there any other opinion on that? Yeah.
No, I agree. It's a rare disease, more common in women. But you see a man, 45-year-old man, okay, idiopathic VF, often they are these, there's a overlap between that and the short coupled torsade, I would feel. And as Anis said, I mean, Professor Belhassen has, I think, a 40-year-old, for 35-year-old follow-up on more than about 30, 40 patients with idiopathic VF with zero mortality on quinidine. So I think that's quite impressive. I think we can go to the next talk now, Anis.
Yeah. Yeah, sure. So, Dr. Deba brother, we can invite the next person to talk.
Please, sir. Please, sir. The stage is all yours. I'm just a
Yeah.
Okay. I think Dr. Siddhant will present because Dr. Milind is not there. Yes, sir, if I'm not wrong. Yeah. Anis, please invite. Yeah.
Yeah, I will invite Dr. Milind, sorry, Siddharth, is that right? To present
Siddharth.
on
So Siddhant is
polymorphic
our
VT.
assistant.
Yeah.
Anis. Siddhant is our assistant professor
yeah,
at Sion
please.
Hospital. He's a good cardiologist, all-round cardiologist, and proficient at intervention also. So we have requested him to take Milind's place for this talk. Siddhant?
Yeah, thank you for the introduction, sir. I'm Dr. Siddhant Yadav, as sir introduced, and I'll be talking about an interesting case of polymorphic ventricular tachycardia. I'll just start sharing my screen in a bit. Yeah. Is it visible?
Yes, it is.
Yes,
Go
it's
on full screen.
Okay. Yeah, I'm just doing that now. Okay. So yeah, our case was a 42-year-old woman. She presented with typical angina since 4 hours. General examination was unremarkable except for a peculiar murmur in the left parasternal region. So her ECG was as follows. You can see the AVR elevation, which is prominent ST depressions all throughout with an RBBB pattern. So our provisional diagnosis of acute coronary syndrome, we started treatment, and before we could do a lot, actually, during taking her off of the ECG, she became unconscious, and her ECG was this. So you can see such a chaotic rhythm. You can see a polymorphic ventricular tachycardia with which is degenerating into almost like a ventricular fibrillation type of pattern. She was promptly defibrillated and stabilized. We checked all the blood parameters as necessary, but there's nothing that which we could find as a cause of it apart from the ischemia. So polymorphic ventricular tachycardia. A little bit about it. This is what the talk is about in general. With a normal QT interval, if you get polymorphic ventricular tachycardia, ischemia is usually the culprit. It is going to be your cause 9 out of 10 times as a general cardiologist, not an electrophysiologist. Or other causes could be the patient could be in heart failure, or he could have other organic heart disease like a dilated cardiomyopathy. So on the molecular level, what happens is there is a huge amount of calcium influx during ischemia, which triggers depolarizations and causes the chaotic activity. There is also an increase in extracellular potassium. This shortens the repolarization, slows areas of conduction, and that sets up re-entry circuits, multiple circuits all throughout, causing the polymorphic morphology of the ventricular tachycardia. Apart from that, there are also structural abnormalities which happen during ischemia. There is a disruption of the connexins. There are free fatty acids which are liberated. As we know, the catecholamine surge, which happens, there are free radicals which are liberated. All of these contribute to causing a polymorphic ventricular tachycardia. These patients can go into VFib as well. So one of the causes, VFib is generally a terminal rhythm, in general just presents as VFib, but it can also be a sequelae, or rather a progression of polymorphic ventricular tachycardia. These can degenerate into a ventricular fibrillation. Coming back to our patient, while shifting her for an echo, after stabilizing her, we were thinking about what could be the cause of the murmur. So an ischemic case, you primarily think about severe MR, but the patient wasn't in heart failure. So that really knocks it down a bit. A ventricular septal rupture is common, but the presentation was in 4 hours. BSR would be a little more delayed. We also thought it could be something else unrelated, or maybe a pre-existing condition. This is what the echo showed. So in the short axis left ventricular view, you can see there is obvious hypokinesia in the anterolateral and the lateral walls, and there is significant mitral regurgitation, maybe moderate to severe mitral regurgitation. In the cath, we couldn't engage the left coronary, but when we engaged the right, we can see this huge dilated tortuous right coronary continuing into interventricular, intercoronary collaterals in the interventricular septum, then going on to a dilated left main coronary artery draining into a vessel which is bifurcating, which signifies that it's a main pulmonary artery. We went back to the echo, and so in the short axis, you can see this is the aorta, giving rise to a huge dilated right coronary artery. We can also see this structure here, which is the left main that is connected to the main pulmonary artery, which is over here. We set down the Nyquist in the echo color view, and we can see the dilated coronary collaterals, intercoronary collaterals in the interventricular septum. This is a hallmark of this pathology. And one of the ways you can suspect a patient of this condition is with this picture on an echo. On the CT, you can again demonstrate the same thing. You can see the left main connected to the main pulmonary artery. The 3D reconstruction nicely showing both the origin of the dilated RCA and going on the tortuous intercoronary collaterals and connected to the main pulmonary artery from behind. This is the view from behind. And the patient was sent for surgery. This is the aorta. You can see the open heart, and you can see dilated intercoronary collaterals, all of these here. You can probably appreciate that the left main is kind of dilated, and definitely dilated, but it also looks thin-walled, and it's attached to the main pulmonary artery from behind posteriorly. So our case was a case of Alcapa, which is an abnormal origin of left main from the pulmonary artery. It's also called Bland-White-Garland syndrome. This was a case of Alcapa, which led to ischemia, causing a polymorphic ventricular tachycardia. We settled on the cause of murmur to be the mitral regurgitation, although there can be other causes of murmur in this patient, as we'll discuss in a while. So how do you suspect these cases? So an adult Alcapa is pretty rare, so you have to check the echo. The echo, you can see a dilated right coronary artery. If you're very lucky or very observant, you might be able to actually see the left main attached to the main pulmonary, but it's really very difficult. Dilated interventricular collaterals, interventricular septal collaterals are a very high, are a red flag. You want to really suspect these cases when you see those. Other findings would be a shiny papillary muscle and a hyperrefractile subendocardium. That's because these patients have a lot of subendocardial ischemia and fibrosis that causes subendocardial fibrosis. On the ECG, you can see multiple things like LVH. There can be left axis deviation. But it can also be normal ECGs. So a little bit about the pathophysiology. I know this is about ventricular tachycardia, but I think this it's an interesting thing to know. So in the neonatal period, we all know the pulmonary artery and the pulmonary vascular resistance is very high. The aortic resistance, almost near the aortic resistance. So the aorta is pushing blood down into the right coronary, and the pulmonary is pushing blood down into the left coronary. So this area is right now in neonates and in the intra-utero period perfused pretty well. Even though the pulmonary is desaturated, it has enough oxygen to keep the heart going. However, after about 1 or 2 months, when these patients start presenting, what happens is the pulmonary resistance starts falling, the duct starts closing, and then this pulmonary artery starts sucking up blood from the left system. And now we're in trouble. Now this area is ischemic, especially because the collaterals aren't well developed now. This is a child. He hasn't had time to develop the IVS collaterals as they appear in older patients. So these patients have a lot of ischemia here, and that results in death in almost 90% of patients within the first year. There are two main reasons of how these patients can survive. First is the patient can have they are ones which are predisposed to having dilated collaterals. These are the ones that survive, but that's not the only reason, because dilated collaterals would just set up a shunt from the aorta to the pulmonary. So the aorta is pushing blood down and the pulmonary is just sucking blood up. There is no time for the blood to perfuse the myocardium throughout. So there's coronary steal. So you need another thing. What do you need? You need the pulmonary vascular resistance to be slightly higher. So I've drawn an arrow downwards, but the flow doesn't really come down from the pulmonary. The flow is still up. I've just shown it so that you know there's a resistance to the flow than normal. There can also be a left main stenosis here at the junction, which can increase the pressure here. This pressure causes a little bit of stasis. The transit time through the myocardium slows down, and that increases the perfusion. These are the patients that survive to adulthood and old age, et cetera, et cetera. So in the adult type, all these arteries are dilated. The aorta leading to the right coronary artery, which is dilated, there's dilated collaterals in the IVS. The IVS is most of the times the site of most of these collaterals, because that is where the most capacitant vessels are. It leads to the left main, which is also dilated many times. And since it's under low pressure, it's under venous pressure, it eventually loses a lot of its media and it develops a vein-like morphology. The hemodynamics, which we already discussed. The clinical presentation, we talked about ischemia. So these infants present with pallid spells, which is basically the equivalent of angina for these patients, for these young children. An adult type is more rare, obviously. These patients have more subacute symptoms like heart failure, dyspnea, something like that. An 18% incidence of sudden cardiac death as the first presentation is possible. So these are more likely in the patients who are of a younger adult group. Ventricular arrhythmias are possible, but as we saw, the biology can be surprising sometimes and they can be asymptomatic. First presentation is very commonly during pregnancy. What happens in pregnancy is the systemic vascular resistance goes down, and then the push of the blood from the aorta is less. The myocardial demand is more, and that can set up patients for ischemia. However, our patient had 2 deliveries and she didn't have any issues with that. So yeah, about the treatment, these guys need to be treated. As we saw, 18% can just drop dead. The coronary button reimplantation is the treatment of choice. You achieve an anatomical repair. You pick up the left coronary artery and with a button, and you suture it to the aorta. Although it's not easy in all kinds of anatomies. Sometimes when the coronary is not really attached in a favorable position, you may need to use the Takeuchi procedure, in which you use a baffle made from the pulmonary artery. So you take tissue from the pulmonary artery and you make a tunnel from the left main across the pulmonary artery into the aorta. It's a very technically challenging procedure. Coronary buttrell reimplantation is a dangerous and difficult procedure for adults because, as we discussed, in adults, the left main is like a vein. So these are very friable vessels and they bleed a lot when you suture them. So in adults, what you prefer is you ligate the left main and you just put a bypass graft into the left anterior descending artery. So surgical treatment on a whole is almost a must for most patients. You have to reestablish the flow, and that changes the natural history of these patients. One coronary system we used to just ligate the left main and leave it off. That's not something that we do right now. Some complications of what can happen after you ligating the alcapa, the left main, it can recanalize. After a while, it can lead to mitral regurgitation. In the Takayuchi procedure specifically, you can get supravalvular pulmonary stenosis, and the baffle also can stenose or it can leak, as any baffle can. The CABG has, that we discussed, it being the treatment of choice, can have a high rate of repeat procedures because there can be graft stenosis because you're attaching it to a vessel which is basically a normal vessel. There is no stenosis there. So you have a lot of redos in these patients. After 50 years of age, it's found that these patients have a few less chance of sudden cardiac arrest, about 2%. So the treatment here is a bit tricky. You need to individualize these patients. That's where more advanced modalities like the cardiac MRI come into picture. So you can maybe try to gauge the amount of myocardium that's at risk, and then make a shared decision with the patient about the risks and benefits. Because these patients will probably be better treated with heart failure medications in general. And some may actually benefit from the intervention and bypass graft, etc. Masterful inactivity may be very useful in these patients. These are older patients. So this is a study by Dr. Yao, and it was a retrospective analysis where they found that around around 37% of the patients, even 37% of the patients after 50 could be managed well medically. This was a retrospective study of case reports. As far as the murmur goes, 70% of these had murmurs. Around 87% of these patients had murmurs, 70% being systolic, which is usually attributed to the mitral regurgitation, which is very common in these patients. There can also be a to and fro murmur, which is due to the intercoronary collaterals through the interventricular septum. They also discussed the mortality. The surgical mortality is not really low, so you need to discuss that with the patients. Even in experienced center, in centers it's about 4%. So that adds another dimension to, if you want to treat this patient or not. So small take-home points. Alcapa can be a cause of ventricular arrhythmias, especially polymorphic ventricular tachycardia or ischemic ventricular tachycardias. You have to suspect these cases when you see dilated RCA on the echo and you see turbulent interventricular septum blood flow. Most of these patients will require surgery, especially the ones who are younger. The preferred surgery is a ligation of the left main with a bypass graft. The treatment, although for older individuals, needs to be individualized. Thank you so much.
Thank you, Siddhant. Actually, this case was interesting, a rare case, but we thought it would. Ischemic VF is most commonly, as Abhinav said, in acute ischemia. But here, when acute ischemia is not the case, then you start thinking of other etiologies. So we thought that although this was a little discussion of hemodynamics, I thought it would be useful for the students to understand this. So Anis and Jaskaran, please take over.
Yeah, it's an interesting case. Rare presentation. It was the first presentation with cardiac arrest in this Alcapa patient, I think, right? It was good.
Yes,
and many times, sometimes, even revascularization, these patients are prone to arrhythmia. So, did you consider any anti-arrhythmic intervention like ICD or medicines after the revascularization or in this patient?
Unfortunately, this
Was
patient.
there any LV dysfunction?
Unfortunately, this patient had further issues and did not make it, which was sad. But what you're saying, Bharat Kantare has raised the same question. What is the role of ICDs? And it's a valid question because in adults, if the left ventricular dysfunction is persistent, there's already been myocardial damage, then they need independent risk stratification. Even if you have revascularized, I feel if there's a large scar, they need independent risk stratification for the sudden death and antiarrhythmic drugs and ICDs.
Yeah. So generally, if after 48 hours of revascularization, if the patient continues to have risk of arrhythmia or SCD, independent of LV dysfunction, many of these patients require an ICD if they survive the insult. And polymorphic VT in the ischemia sometimes are amenable to ablation because some of these are precipitated by ectopics arising from near the Purkinje fibers in the septum, near the scar borders. So we had a few patients like that where actually one patient is surviving without an ICD after ablation. Two others we had the ICD implanted after ablation. And at least in 2 cases, after ablation of the ectopic from the Purkinje fiber area, there was no recurrence of VT. So, so these are options which are available. I mean, in this forum, I thought I would discuss that also. Yeah. Any other, Dr. Jaskaran, you want to add something?
Yeah. So I had a question. Yes, sir. Maybe you can elaborate on that. So more recently we have seen a lot of cases where patient underwent late revascularization, and then on day 4, day 5, patient started getting polymorphic VT or short couple PVC induced VF, and then they were referred for medical management. So, what do you think? I mean, I have never seen a case where you have done revas within 12 hours and you have got a VT in that 3 to 40-day period. So, any sir comments on that?
I think this is an important point both of you have raised, and which should be for the clarity in general for the students. That many times this dilemma is that the patient has got VT and VF, acute coronary syndrome, acute myocardial infarction, and should the patient be offered a defibrillator? So I think it's one thing should be clear that within the first 48 hours of an acute event, when you get ventricular arrhythmia, is not an indication for a defibrillator. These are the what you call the primary arrhythmias. But arrhythmias, dangerous ventricular arrhythmias that occur after 48 hours of an acute myocardial infarction, these are the ones which likely will need a defibrillator. Having said that, you have to individualize patients who is having ongoing ischemia, because remember, for ischemia, the treatment is revascularization. And for scar related or evolved infarct related later arrhythmias, the treatment is mainly antiarrhythmics, ICDs, or in some selected cases, ablation. So I think this concept should be very important for the students. It's often a dilemma, that what should be done in this case. So I thought this point needs to be crystal clear that, and all the studies which are saying that after 6 weeks of a large MI, consider ICD with severe LV dysfunction, that is for primary prevention. That is for people who have never had ventricular tachycardia. But suppose someone 1 week after a MI or 3-4 days after a MI event has had a ventricular tachycardia, they do not fall into this guideline of 6 weeks. They are the people who probably definitely need protection from sudden death.
Yeah.
Thank you, sir.
So just to remind, there are a few questions in the Q&A box other than this chat box. If we could answer few of them. Is another Q&A box on the right side.
Yeah, I saw that. So there is a question about drug in polymorphic VT during ST elevation MI. I think Dr. Yash also can answer that. Polymorphic VT, definitely ischemia revascularization is the first step. Then some of these patients respond to Silocard or lignocaine, and most of the time, if it is happening within the first 48 hours, some of these patients do not respond whatever we do, and then ECMO or some mechanical support may be required to tide over the 48 hours. And then in the post-MI period, beyond 48 hours, if there are ectopics related, these patients may sometimes respond to Silocard, and then once they respond with suppression of VPCs, you may consider them putting them on mexiletine. I don't have any information on quinidine in this setting because it was probably not used much in post-MI situation patients. So mexiletine may be useful and in long term in patients who respond to Silocard. That has been my practice. So what is your opinion, sir?
I think Anis, the question comes because in practice, most of the students would have seen in their setup the first drug to be given is amiodarone. That is what I universally see, and that is not the correct way to go. Please remember, in ventricular tachycardia, amiodarone is a third line drug. The first is lignocaine, second is beta blocker, or the first may be beta blocker, second may be lignocaine, depending on the clinical setup. Agreed, lignocaine may not work, but before trying amiodarone, these two are to be tried. And in polymorphic VT, amiodarone certainly should be used with extreme caution because many of these patients have underlying QT prolongation or borderline QT. The third thing is, of course, treating a VT storm. So sedation, knocking out the sympathetic drive is extremely important. And for heaven's sake, someone who is hypotensive and on inotropes, think 100 times before using IV amiodarone. I think most students are exposed to the misuse of amiodarone in an acute critically ill patient with borderline hemodynamics and polymorphic VT. I think so that message should go loud and clear, I feel.
Yeah. There's another question about stellate ganglion block. Definitely it has its role in patients who are hemodynamically, when it is possible to do stellate ganglion block. And even before stellate ganglion block, I would recommend deep sedation or IV, propofol-based anesthesia if the patient continues to have recurrent VF in the post-MI period. Often it is not possible because the patient's hemodynamics is not good. That is when you consider ECMO or something. And if possible, and if the sedation or deep sedation with propofol works, it usually works within the first 30 minutes. And then you may slowly, try to, meanwhile, arrange an ablation or stellate ganglion block, which should work in many cases. I have tried stellate ganglion blocks in post-MI situation in two cases only. And both those cases, it did not work. But general anesthesia and high-dose Silocard worked. And also sometimes works. Yeah. So, and there is another question: role of antiplatelet staying for ischemia management. Definitely, there is no doubt, right? I mean, antiplatelets has to be maintained. Also, sometimes you may require a re-angiogram to make sure that the coronary flow is adequate or good, and there is no stent thrombosis. Many cases, statins also. There is another question about inotropic support. What to do? Yeah, it's inotropic. That is a critical care question. Like you have to maintain the patient on inotropic support to maintain adequate perfusion to prevent acidosis, hyperkalemia, renal failure, and all those issues.
I think
meanwhile,
Anis,
trying our best.
Sorry, Anis, the question for inotropes probably is because there is a choice between dopamine, dobutamine, and noradrenaline. In this setting, now the general impression is that noradrenaline is less arrhythmogenic than dopamine. I don't know if this is borne out by randomized studies. Having said that, noradrenaline is more for peripherally caused hypotension like septic shock rather than cardiogenic hypotension. So one has to individualize and see. And dobutamine definitely should be avoided when there is hypotension. Milrinone, again, very limited data of milrinone. It's more of the heart transplant surgeons use. We don't use in cardiology much of milrinone.
Yeah, I think so. I think that will clearly put what Dr. has mentioned.
There is one more question below. What ejection fraction flecainide should be avoided? Now, they're very interesting question. Actually, in ischemic heart disease with left ventricular dysfunction, please avoid flecainide in ischemic heart disease. And in all other diseases, generally flecainide, when there is a normal heart structurally and no bundle branch block on the ECG, you can use safely. There is one structural heart disease where flecainide can be used, especially if there is already an ICD, you definitely can use it. That is arrhythmogenic cardiomyopathy. In arrhythmogenic cardiomyopathy, you can add small doses of flecainide. It is there in the guidelines also now. But otherwise, in general, remember when there is severe ventricular dysfunction or significant ventricular dysfunction of any etiology, avoid flecainide.
Yeah.
One
Okay.
comment regarding Alcapa, if you have the time. I'm taking care of a 25-year-old patient who had undergone Alcapa surgery and mitral valve repair at 5 years of age, and presented recently with sudden cardiac arrest, ventricular tachycardia, and we looked at the papers. He had atrial fibrillation going on for the past couple of years, LV dilatation, LA dilatation. Took care of the VT storm medically, optimized the medications, got him back into sinus rhythm in the next few weeks. Patient CF is now 50-55%, doing well on minimal medication and just beta blockers. And we avoided defibrillator already. So very much we need to individualize therapy for these people.
I think there may be many more comments, Anis and Jaskaran, but I think in the interest of time, already overshot. Let's call the third talk and the chairpersons. I think Rajiv is here. Rajiv and
Professor Rohit Manoj is there.
Rajiv and Rohit are there. Both are there. So Saurabh is just freshly passed DM with the gold medal from Sion Hospital, for which he's going to give everybody pedas after this webinar. So Saurabh, please start with your interesting case.
Thank you, sir. I will start sharing the screen, sir.
I think there is some background noise coming from somewhere. Can we mute everyone else except the speaker? Yeah, Saurabh, go on the full screen mode and start. Yeah, we see the screen. Can you put the full screen mode and start your presentation? We don't see the full screen mode, Saurabh.
Sir, yes, I am doing, sir. There is some issue with my PC, sir. I will figure out, sir.
I think you need to click down on the full screen mode, down on that taskbar.
Yes, sir.
Yeah, we can see it now. Please start.
Yes, sir. Good morning, everyone. I am Dr. Saurabh Limay, and today I will be presenting a fascinating and challenging case which is titled Idiopathic Myriad Malignant Ventricular Tachycardias. Our case involves a 36-year-old woman with no known comorbidities who had been experiencing recurrent palpitations for the past 4 years. These palpitations were rapid, regular, and paroxysmal in nature and had a sudden onset and termination, each lasting 15 to 20 minutes. Importantly, they were not associated with pre-syncope or syncope. On November 27th, in the morning, she again experienced palpitations. This time, they were associated with giddiness and vomiting and eventually progressed to a syncopal episode. She was taken to the emergency department at an outside hospital, where the monitor showed a heart rate of 200 beats per minute, a 3D pulse, and systolic blood pressure of 70 mm of mercury. Due to her hemodynamic instability, only limb leads were attached initially. The ECG suggested a broad complex tachycardia at a rate around 200 beats per minute with two predominant QRS morphologies, as shown here. A subsequent ECG again showed a broad complex tachycardia with a rate which is around 180 beats per minute with multiple QRS morphologies. And lead V1 is again showing bidirectional ventricular tachycardia. Shortly after this, the patient developed ventricular fibrillation. CPR was initiated immediately and she was defibrillated with a 200 joule shock. along with administration of intravenous lignocaine. Post-resuscitation ECG showed sinus rhythm with 1:1 conduction. There were asymmetric T waves in anterior leads and biphasic T waves in the inferior leads. Routine lab investigations were within normal limit, including cardiac enzymes and electrolytes. She denied any family history of sudden cardiac death or history of cardiac disease or arrhythmia. There was no use of digoxin or any alternative medications. Her echocardiogram showed normal left ventricular systolic function with an ejection fraction of 0.6, along with mild mitral and tricuspid regurgitation. There were no structural abnormalities noted. We proceeded with a cardiac MRI as a part of structural evaluation. The MRI was unremarkable. There was no evidence of late gadolinium enhancement, ruling out infiltrative and inflammatory causes. We performed both a treadmill test and an adrenaline provocation test to evaluate for catecholaminergic polymorphic ventricular tachycardia. Both tests were negative. The treadmill test did not reveal any VPCs or bidirectional or polymorphic ventricular tachycardia. As shown on the slide, the adrenaline provocation test is more sensitive than treadmill testing for CPVT. The adrenaline provocation test, which is also called epinephrine, is performed after 10 minutes of rest with a stepwise increase in infusion of adrenaline every 5 minutes. A positive test is defined by more than equal to 3 beats of polymorphic ventricular tachycardia or bidirectional VT, and it should be avoided with prolonged QT and terminated in patient who develop elevated systolic blood pressure, non-sustained VT, T-wave alternance, or becomes intolerant. Comprehensive genetic panel analyzing over 3,000 genes was performed and returned negative. Specific genes commonly implicated in such cases, which are ryanodine receptor, calsequestrin, and the potassium KCNJ2, were also negative. As shown here, the genetic yield in CPVT is variable. While the ryanodine receptor mutations are the most common, overall yield is limited, especially in patients without classical features, like our patient who had no exertional symptoms and both her treadmill and adrenaline provocation tests were negative, further reducing suspicion of catecholaminergic polymorphic ventricular tachycardia. We diagnosed her as having idiopathic bidirectional VT and discharged her on a non-selective beta blocker propranolol 20 mg twice daily. Let us now review bidirectional ventricular tachycardia, which is defined as ventricular tachycardia with every alternate beat showing change in axis or morphology. The differential diagnosis for bidirectional VT include conditions that predispose cardiac myocytes to delayed after depolarization leading to triggered activity. With history, we ruled out any digoxin overconsumption as well as aconite poisoning. Genetic panel was negative for genes involving CPVT and KCNJ2 was negative, along with no evidence of clinical trial that ruled out this rare form of long QT syndrome called Anderson-Tawil syndrome. Echo and cardiac MRI ruled out myocarditis and sarcoidosis, and her presentation, negative enzymes, and echocardiography ruled out acute ischemia. For CPVT, we had performed adrenaline provocation as well as treadmill test, both were negative. The primary mechanism behind bidirectional VT is delayed after depolarization, which occurs due to calcium overload in phase 4 of action potential. For example, digoxin, which is a classic example, inhibits this sodium-potassium ATPase pump. That leads to accumulation of intracellular sodium. This sodium is exchanged for calcium with this sodium calcium exchanger pump. This calcium is taken up by sarcoplasmic reticulum, and this overloaded calcium is released, especially if in phase 4 of action potential, that can lead to delayed after depolarization. Bidirectional VT was first described in association with digoxin back in 1920s. There is one interesting mechanism which is called ping pong hypothesis for bidirectional VT proposed by Baher et al. They formulated a computational 2D model of a rabbit heart and with his Purkinje system. And once with pacing, as the cycle length reduced, it crossed threshold for bigeminy in the first site of his Purkinje system. That itself aggravated rate which exceeded the threshold for bigeminy from the second site. This trigger of beat 1 lead to trigger in beat 2 from the second site. If more than such 3 sites are involved, it can lead to polymorphic ventricular tachycardia. One of the etiology of bidirectional VT is aconite poisoning with similar mechanism of calcium overload causing delayed after depolarization. It is found in herbal, Ayurvedic, homeopathic, and Chinese traditional medicines, and many such cases have been reported in literature. CPVT affects predominantly 1 in 10,000 patients. It is caused by population. It is caused by mutation in ryanodine receptor or calsequestrin gene with autosomal dominant or recessive form of genetic mutation. ECGs are often normal at rest, but they may have sinus bradycardia with predominant T waves. As per ESC 2022 guidelines, beta blocker receive class 1 recommendation. ICD implantation is recommended for aborted cardiac arrest. Flecainide and left cardiac sympathetic denervation receives class 2A recommendation. However, there is some controversy around ICD use in CPVT. This IHRS consensus by Wilde et al. Advises caution as painful ICD shocks may increase sympathetic tone and exacerbate arrhythmia. This was supported by a study of 136 patients, which was a cohort observational study with aborted sudden cardiac arrest who were on beta blockers, flecainide, and sympathetic denervation. 58% received ICD therapy, and over a median follow-up of 4.8 years, those without ICD had better outcomes in terms of sudden cardiac death, sudden cardiac arrest, appropriate ICD shock, and syncope as compared to those with ICD. Another rare cause is Anderson-Tawil syndrome, also called as long QT syndrome 7. Diagnosis requires at least 2 of the following: prominent U wave with or without QT prolongation, bidirectional and or polymorphic VT, facial dysmorphism and abnormalities in extremities, periodic paralysis, and loss of function gene mutation in potassium channel KCNJ2. So to conclude, here are key take-home messages. Bidirectional VT is rare but recognizable ECG pattern. Delayed after depolarization are important for pathogenesis. Management depends on underlying etiology. For our patient, no specific etiology was found, and early recognition and treatment is needed to prevent sudden cardiac death. Before I end, I would like to leave you with a quote that perfectly captures the spirit of clinical inquiry and journey we undertook through this case. Thank you.
Thank you, Saurabh. I think you have such a rare case, and you have well summarized the case and presented well. I think one of the important causes in our setup would be to rule out digital toxicity, which you have ruled out. And other causes are rather uncommon and rare, and which require systemic organization. You also highlighted the controversies of role of ICD. Probably Dr. Lokhandwala can tell us about this. Thank you.
I think Rajiv, any comments, Rajiv? I feel that many of these we are coming around to the use of non-selective beta blockers. While nadolol has been this thing, we don't get it, but propranolol is apparently equally good. But there is some background noise coming from one of the speakers. So can we turn mute? Yeah. So we must remember that if we are using propranolol, it should be in the highest tolerated dose. We should not just start 20 milligram or 40 milligram, leave it at that. Please give the highest tolerated dose, and if required, add flecainide also. So I think these are the two important messages for the postgraduates that I would like to give. It's just like ARNI in heart failure. Try to achieve the maximum tolerated dose. Similarly, in these inherited arrhythmia syndromes, when you are using a propranolol, give the highest tolerated dose. So if Rajiv doesn't have any comments, then we can move to the. Are there any questions in the chat box of Rohit? Or any questions? No,
Sir,
yeah, there is
a question. So there is a question from Vijay that can TMT be used to test the adequacy of the dose?
Sir, I hope.
Yeah, can we first tackle this question? Can we first tackle? Hello, can we first tackle this question, which is very important? How do we judge whether the medicine is effective? Well, in catecholinergic VT form of the VT typically comes, but the ones which are exercise induced usually come at a particular heart rate during exercise. So that is one good thing. So those which were exercise induced, in them a repeat stress test and you reach that level, beyond that level, and you don't induce, gives you reassurance, and that is good. But there is a significant subset which is not exercise induced. In them, really, we cannot rely on the stress test to say that the patient is adequately protected. Yeah, there's another question.
So there in the Q&A box, there is another question. Dr. Ramdev Yadav has commented that propranolol 20 milligram BD is too low a dose. Any comments, sir?
Yeah, I agree. I fully agree. The question is, this patient initially had a borderline blood pressure, but then slowly you should increase it. They do tolerate more and more doses over a period of time. So certainly you can go up to 80 milligrams a day, 120 milligrams a day, or even higher. And yes, this certainly is at present a relatively low dose for this patient, and we are trying to step it up. It's a good point.
Sir, hello, sir. Yes,
Yes.
sir.
You're audible.
Yes,
Hello.
yes.
Sir,
Yes.
I have one question. So some network issue is there. Should we do TMT in follow-up for these patients?
We should, but as I said, the ones which were previously provoked on TMT, for them, a repeat TMT is definitely indicated, and we can, if they do not have any arrhythmias, even triplets, even multifocal PVCs during a repeat TMT, then we can say with a reasonable degree of certainty that they are protected. So we should do a repeat TMT, yes.
So
for those which are not exercise induced, for those which are not exercise induced or reproducible, we should do a repeat long-term holter, maybe a 1 week holter.
Yes, so there is another question. If someone develops a junctional brady due to a higher dose of beta blocker, let's say propranolol, shall you pace? Let's say
I think let us reserve this for the next case.
Okay, sure, sir.
In those with asthma, I think it's a propranolol can't be used. Yes, that's a valid point. There is some role of you may use flecainide in those with asthma, and there is also some role of calcium blockers in these patients. Although these are small groups of patients who have been tried, but flecainide is certainly been tried and is recommended.
So is sympathectomy helpful in these cases if beta blocker is not tolerated?
It is in the guidelines also, as was pointed out by Saurabh. So, but unfortunately, it's a relatively simple surgery, but yet done by very few centers. So we should promote, and probably the next case will highlight this also.
Okay, sir.
So let's move to the last presentation by Sriram. Sriram is a faculty again at Sion Hospital. He's an assistant professor and a good academician. Sriram?
Yes, sir. Am I audible, sir?
Yes, you're quite clear.
Okay. Is my screen visible, sir?
It's visible, but you need to go on the full screen mode.
Yes, yes, sir.
Yeah, we are still not seeing the full screen. We are seeing only half the screen. It's not on the full screen mode for us.
Yes, sir.
I think you have to go down and click the full screen mode. Yeah, now it is okay. No, it's gone again.
No, yes, yes, yes. I'll start from the last.
Yeah, it's fine. Go ahead.
Very good morning to one and all, and thank you, IHRS and Dr. Lokhandwala sir, for this opportunity to present this case. Today, I'm going to be discussing this unusual case of bradycardia tachycardia syndrome. Our patient is a 16-year-old boy who is symptomatic since the last 5 years, who was primarily referred to us with recurrent exertional syncope and near syncope with tonic posturing, which was associated with prompt and complete recovery. He was noted to have bradycardia, so he was primarily referred to us for a permanent pacemaker. He also did not have any sweating or cyanosis, and these episodes of syncope were associated with a prodrome of rapid palpitations, which the patient realized, and he used to sit down, and there was no injury so far. And there was also one episode of urinary incontinence. There has been an increased frequency of these episodes since the last 1 month, the last one being particularly dramatic. The patient was at a wedding where he was invited on the stage for a photography. When he rushed onto the stage and he sat down on the front row, and suddenly he started developing this prodrome. One of the relatives who was of medical background knew this, and hence he was made to immediately lie down, and they knew that it automatically subsides, as a result of which he did not have any syncope, but this episode did occur. Due to the bradycardia which was noted, he was started by a local doctor on orsiprenalin, which gave him some relief, but definitely not complete relief. The clinical examination was unremarkable, except for the fact that there was significant bradycardia with a pulse rate of 48 per minute. So this is the baseline ECG. You can see that it is a bradycardia with a heart rate of around 48 per minute. The escape rhythm, it is narrow, which is suggestive that it is probably a junctional rhythm. And you can see that there is isorhythmic AV dissociation, which is signified by the fact that there is no constant PR relation. Some places it is short, while some places it is long, and some places it may have fused into the QRS complex. The other particularly notable feature is that the QT interval is normal, and there are these prominent tall T waves which are noted in lead V2. There are also these non-significant U waves, as they were predominantly only noticed in the mid precordial leads, and they were of the same polarity as the QRS, as the T wave, as a result of which it is not significant. Uh, the, because of the particular history which we had received about the post-exertion symptoms, we decided to record an ECG post-exertion. So the patient was made to walk rapidly and climb a few stairs, and as soon as the prodrome developed, he was made to lie down, and the ECG was documented when the pulse rate was around 200 per minute. So suddenly we noticed this was the ECG which was present. You can see that it is a rapid heart rate. It is extremely bizarre. The QRS complexes are chaotic and all out of the way. You can see that there are, if you want, you can particularly note down on lead 2, where you can see that there are initial uh, more positive QRS complex followed by a abrupt transition to a negative QRS complex. Then gradually, it is not a uniform morphology. Basically, it is a polymorphic, it is like a polymorphic VT. You can also see that there are some intermittent narrow complex. The last beat over here, as you can see, it is preceded by an ectopic P wave. So based on this, we had this diagnosis of an exertional polymorphic VT, which was going towards the favor of one particular diagnosis, which was a catecholinergic polymorphic VT with a baseline bradycardia, which is due to sinus node dysfunction with isorhythmic AV dissociation and junctional escape. Now, this was a real therapeutic dilemma. We were not sure about whether there were two etiologies. What do we treat? Whether we treat the bradycardia first or do we treat the tachycardia? Because the patient primarily presented to us for a pacemaker, but now we have noticed that he also has a polymorphic VT. So what do we do? Do we implant a pacemaker or do we give beta blocker as a therapy for the VT, or do we put an ICD? So what do we do? This was the main issue. So we thought that we go ahead and implant a pacemaker, associate and give him a maximal tolerable dose of beta blocker. So we started off with the pacemaker implantation. So we first fixed the atrial lead and we paced the atrium at a very rapid rate of around 160 beats per minute, just to see if there is 1:1 conduction and note for the robustness of the AV conduction. We noticed that because it was intact, there was no problem, and hence the patient was implanted with an atrial-based pacemaker. This was the post-pacemaker ECG, which shows that there is a constant PR relation, and each P wave is preceded by a pacing spike, and there was no other grossly visible abnormality. Next line of action was genetic testing. Since the patient had both polymorphic VT and sinus node dysfunction, we were not sure whether it was just one unifying etiology or whether there could be multiple genes. So we went ahead with the whole exome sequencing. However, on the third day post pacemaker, we wanted to check whether the strategy of optimal dose of beta blocker. He was started on 20 milligram propranolol twice a day, but beyond that, his blood pressure was not allowing. It was not permissible for us to increase the dose. So what we did on the third day after the procedure, we did a Holter, 24-hour Holter, where he was made to do exertion by climbing a few stairs and walking in the corridor rapidly. We noticed that there was presence of around 65 episodes of ventricular tachycardia, which can be noticed, as you can see in this Holter report. You can see the same bizarre complex as it was there, which was noted during the clinic. So because of this, we went ahead and we planned for doing a thoracic sympathectomy to further suppress the sympathetic tone. So now this is the actual thoracic sympathetic chain, where you can see that the main supply, the sympathetic supply, is from the inferior cervical ganglion associated with the T1 to T4 thoracic sympathetic ganglia, and the nerve of Kern, which is basically the high sympathetic tones supply to the heart. So we went ahead and we excised that through a open procedure. Ideally, it can be done by video thoracoscopic assisted procedure, but in this case, it was a small child, it was easier to relatively open. And this, as you can see, is the tissue or mass which was removed. Like it was the cervical, as the thoracic sympathetic chain, which was excised out. 3 days after the sympathectomy, we again wanted to check for the therapeutic adequacy. So what did we do? We did a Holter with the same strategy and we made him do exercise. But this time we noticed that it was a huge wonder that there was not a single episode of ventricular tachycardia. So we were now sure that we have achieved at present a temporary therapeutic achievement, which is hopefully a sufficient one for the long time. Now come the diagnostic and therapeutic dilemmas. Now, was it merely a coexistence of the presence of sinus node dysfunction and ventricular tachycardia? Or was it associated as part of a genetic syndrome? Or is it was due to some common pathology? How do we go ahead and evaluate these patients? And what is the sequence of addressing these patients? This is, first of all, a very unique case of tachybrady syndrome, because traditionally what we observe is that tachybrady syndromes have alternating episodes between sinus node dysfunction and atrial tachyarrhythmias. However, here we had a polymorphic VT with sinus node dysfunction. So differentials would be either a genetic cause or an idiopathic cause. The genetic cause, we went ahead with the whole genome sequence, ideally in a CPVT, we do the sequencing where the most common genes, which we had discussed with Dr. Arthur Wilde, who is the world's foremost authority on inherited arrhythmias via telephonic conversation. Based on his advice, we are planning to basically check for ryanodin receptor mutation, which is found in almost 60 to 70% of these patients. The other most common one is calsequestrin, but there are other rare ones like as Dr. Saurabh has already enumerated in the previous presentation. So what are the clues that we can see on ECG in these patients with CPVT? The PVCs which are there are usually late coupled PVCs. They usually have LBBB with inferior axis or they are RBBB with a superior axis. Exercise was noted to have significant increase in the PVC burden. They initially appear at higher workload and they are monomorphic. Later, they suddenly transition into bigeminy, then polymorphic couplets, and finally into complex arrhythmias. It was noted that all these patients have an individualized constant upper limit of heart rate at which these arrhythmias are initiated. Exercise-induced PVCs were noted to have they are usually broad complex with a QRS of more than 120 milliseconds with a higher coupling interval, as previously mentioned, with more than 400 milliseconds. And they usually promptly disappear with recovery. One other exercise protocol which we can do is a burst exercise testing protocol, where as soon as the exercise test is started, there is a rapid increase in the rate of the exercise intensity is increased such that it is a burst protocol and it can induce 63% can be provoked by this. So let us review the literature of such similar cases. So this review article by Dr. Fagioni et al. Showed that the calsequestrin was a more common gene which was noted with such a presentation with polymorphic VT and sinus node dysfunction. Sometimes they may also have missense ryanodin receptor mutations. Those patients of the ryanodin receptor mutations were it was noted that around 5 to 20% of CPVT had sinus bradycardia and 16% had other supraventricular dysrhythmias. Some were tachy and some were bradycardia. And 38% of these patients were detected by Holter monitoring. Another notable feature was that atrial fibrillation significantly increased the risk of CPVT trigger, and the coexistence of sinus node dysfunction is one important trigger. One of the factors is that which was noted in mouse models was the in patients with in the mice with calsequestrin mutation, where there was loss of function there due to diastolic calcium overload. There was regional microfibrosis noted in the region of the SA node, which could be a potential cause of sinus node dysfunction. The one important protocol which we have to remember, the basic idea behind that is VT in these patients is it is basically a critical balance between accelerated sarcoplasmic reticular calcium loading, which is due to a beta adrenergic stimulation, and there is a diastolic interval. So the shorter the diastolic interval, lesser is the sarcoplasmic calcium loading. So this is the basis of which we do atrial pacing. So when we rapidly pace, which is a non-beta adrenergic based rate increase, it will shorten the diastolic interval and hence reduce the sarcoplasmic reticulum calcium loading and thus suppress the ventricular ectopic activity. But this has only been noted in mice, and such a study has still not been done in humans. Another study by Dr. Sumitomo et al. From Japan, where they did a study on around 8 patients of CPVT who underwent EP study. They noted that around 50% of these patients had prolonged sinus node recovery time, and 25% of them had atrial flutter, which was induced by low atrial pacing, and 25% had atrial fibrillation, which was introduced by isoprenaline. Both sinus node dysfunction and AV node dysfunction was present in patients with an atrial arrhythmic substrate, which induced atrial tachyarrhythmias. So this shows that these patients of CPVT are not just those patients who have a ventricular substrate, but they have supraventricular, AV nodal, and atrial substrates as well. Around 3 to 19% of CPVTs, they can have atrial arrhythmias and a high risk of atrial fibrillation. Because of these atrial fibrillation, these patients, if they have been implanted with an ICD, they can have a high risk of inappropriate ICD shocks, and hence they need careful follow-up. However, again, this study has its own limitations in the fact that it was just 8 patients, and hence the EP studies of these 8 patients which is quite limited to be able to generalizable to the entire population. The sinus node recovery time and SA conduction times also change with age and autonomic tone. Hence, we are not very sure about how this can be generalized to the general population. What is the role of drugs in CPVT? Though we have seen repeatedly that beta blockers have a very significant role in suppressing exercise-induced ventricular ectopy, but it does not necessarily translate into a long-term success. The reduction of heart rate threshold for ventricular arrhythmias has been noted with beta blocker, as a result of which there is a high significant cardiac event rate, even though on therapy. The preferred drug is nadolol at a dose of 1 to 2 milligram per kg, but propranolol and nadolol did not have any significant differences as noted in previous studies. The other drugs which can be used are flecainide due to ryanodine blockade, receptor blockade, and also sodium channel blockade, and hence it reduces the triggered activity due to the delayed after depolarization. Other drugs like propafenone, verapamil, ivabradine, and dantrolene do not have any sufficient evidence. Dantrolene, as we know, is the direct ryanodine receptor blockade. The next line of treatment in these patients is sympathetic denervination. More pronounced effect on ventricular fibrillation was noted, the onset of ventricular fibrillation, than occasional torsades points. The multi-center study of around 63 patients was done, where it was noted that the major cardiac events reduced drastically from 86% to 21% over a mean follow-up of around 37 months, which had a significant p-value. Now we come about the most controversial question of all. What is the role of ICD in CPVT? Around 85% of the ICD-related complications are noted over a mean follow-up of 8 years, and 85% of these patients with CPVT have ICD-related complications. The shocks increase the sympathetic surge, and the associated pain and fear can lead to a lethal electrical storm and incessant VTs, which can be greatly traumatic to the patient. Around 20 to 30% may have inappropriate ICD shocks. As we have previously seen, the probable cause could be oversensing of atrial fibrillation and supraventricular arrhythmias. Around 99% of the shocks for VT have failed, even though they were appropriate. Whereas if those shocks were delivered for ventricular fibrillation, they were noted to be successful, as noted in this study by Dr. Nordkamp et al. Another meta-analysis of around 53 studies of patients with CPVT, including 1,429 patients, of which 35% of them had ICD implantation. It was noted that at least one appropriate shock was noted in 40% of these patients. 21% had at least one inappropriate shock, and 20% had an electrical storm. And 60% of the deaths due to ICD-associated due to the ICD delivered shocks leading to incessant VTs were noted. Another international CPVT registry noted that there was no definite survival benefit with ICD. Hence, it is a very controversial and of questionable value. ICD should thus not be placed in a patient without prior sympathectomy and with maximal tolerable dosage of beta blocker. And hence, it should be kept as a last resort after expert opinion when all other therapies have been tried. Catheter ablation might definitely reduce the risk of ventricular arrhythmias, but it does not eliminate the substrate. Hence, there is no long-term role of a catheter ablation. So these are the final take-home messages. CPVT and sinus node dysfunction can coexist, as can be noted in around 5 to 20% of patients with CPVT with ryanodine receptor mutations. Beta blockers at maximal tolerable dose is the cornerstone for CPVT therapy, though alone it may not be sufficient. Sinus node dysfunction with CPVT, the treatment of choice would be atrial-based pacemaker implantation with maximal tolerable beta blocker dose, with the atrial rate being kept higher than the baseline sinus rate. If an inadequate response is noted with this, then sympathetic denervation is the next line of action. ICD implantation is a completely last resort after expert opinion. The future might definitely have some role for gene therapy with maybe some small interfering RNAs for ryanodine receptor and for calsequestrin, as these are the most common noted mutations. Thank you.
Thank you, Sriram. I think we have shot over time by about 20 minutes, but Rajiv and Rohit, any comments?
Sir, I have only one question. I mean, as a general cardiologist, your is a very rare case, first of all. And so, wonder why put a single chamber pacemaker and why not dual chamber pacemaker? So, I mean, as a general cardiologist, one will feel insecure. Are we comfortable only with single chamber pacemaker?
So, Rohit, I will probably answer that. I agree that AAIR pacemakers, and actually, I know these are rare cases, but that's why I told Abhinav to concentrate on the common causes of polymorphic VT. I think many are unnecessarily insecure about putting only an atrial lead. I think if the AV node is pretty robust, you must check that the AV node is robust. By simple pacing the atrium, then the chance of these patients developing a sudden catastrophic AV block is almost unknown. So if at all they do develop AV nodal problems in future, then it's a gradual process. And when you go for replacement of the pacemaker, you may put a ventricular lead. I'll put the other way around. You put so many unnecessary ventricular leads, cause pacing induced dysfunction or damage to the tricuspid valve. And anyway, within 15-20 years, many times those leads get damaged. Then you do removal of that lead and put another lead. Is it worth it? So I think though AAIR has been almost given up except by a few implanters, I'm told that I'm one of only a couple of people in Mumbai who implants AAIR. I think it is a forgotten art which should be revived.
Thank you.
Excellent case, sir. And it highlights where nothing works. Sympathectomy will definitely works, because for take-home message for all is that if patient is having incessant ventricular tachycardia, VT is strong, we should not go for AICD. We should always think of sympathectomy because it always works. And excellent case, sir. Excellent and unusual case. Yes, sir.
Yes, sir. May I
I
ask
think for the postgraduates, Deba, there were the postgraduates or for the students, and for excellent point by Rajiv. Sometimes when there is a VT storm, whatever it may be, old infarct, cardiomyopathy, hypertrophic cardiomyopathy, patient comes with VT storm, the cardiologists get panicky and send us a message that should we put a defibrillator. The one contraindication to implanting defibrillator is a VT storm. Because what will the defibrillator do? It will give shock on shock on shock and deplete. I have had once a defibrillator depleting within 3 days when it was put in a VT storm. And even if you put it off with a magnet, even if the patient has a ICD and comes VT storm, put remote pads and put a magnet so you have control. But then, of course, you have to have careful supervision of the patient. So that's a very important point. Do not implant an ICD during a VT storm.
Sir, about your, as usual, very valid point, as you said. Now coming back to this single chamber pacemaker, like this patient had a narrow QRS. Had this been a patient who had, let's say, sinus node dysfunction, polymorphic VT, a little weird, we don't know how it will behave in long run. We exactly don't know that the genetics also, and had a wide QRS complex. Do you still put, let's say, AV node is robust?
No, if it's a wide QRS, you put a ventricular lead, no doubt about it.
That is what, yeah, because it might progress or it may
Yeah,
be
no doubt.
allowed.
It has to be a normal ECG except for sinus bradycardia.
Got it.
Sir, one last question. Should we pace at higher rates in these patients who are having bradycardia along with ventricular arrhythmias, as in this patient?
I think so. Especially this is very valid for anyone with QT prolongation. Or sometimes we ablate the AV node and put a pacemaker. These are situations where a normal rate should be at least 70 to 80, or sometimes in the initial stage even 80 to 90. Don't keep it at a 50 backup. That's another important point. These are patients who you should have a little higher rate of what you call lower rate setting. I think there are a couple of questions in the chat box about
in the Q&A box. There are a couple of more important, or I think more relevant questions in the Q&A box. One is one Dr. Ayankar has asked, is there any side effect of T1, T4 sympathectomy?
There is, and someone else has asked bradycardia for. There is. In fact, we have published this in the IPJ, the hemodynamics and chronotropy following sympathectomy. So, in fact, one of the things of sympathectomy is the moment the surgeon cuts the trunk in some of these patients, they immediately fall in sinus rates. So many of these patients already have a pacemaker or ICD, so it doesn't matter, but you have to be ready for that. The anesthetists are ready for that, those who are assisting in these procedures. Blood pressure also, there is a transient drop, and later on it picks up back to the baseline value. But in some, there's a persistent sinus rate about 5 to 10 beats per minute less than what it was before sympathectomy.
So in the chat box, I think those questions you have answered mostly.
There was something about QT prolongation, and if the patients on long QT syndrome develop bradycardia with propranolol and
Right, sir.
junctional rhythm, then of course these are usually will be some symptoms of fatigue and tiredness. So you'll have
Right.
to weigh the balance between reducing the dose of propranolol versus, if there really has been malignant presentation, then put a pacemaker and continue with high doses of propranolol.
Like this case.
Yes.
I think it's a great session. Concluding remarks from you, and I must thank Rohit Manoj
I
sir,
think maybe
Karan
we
Rajiv
can
and-
ask concluding remarks from our IHRS President Ajay.
Oh,
A quick
that's
wrap up.
great. Yes, sir. If sir is there, yeah.
Thank you, Yash, and thank you, everybody. All cases were excellent, and we can see Dr. Yash's mentorship of all the group and what Sion Hospital group is presented. Fantastic cases. We had a great time. I think great learning and academic experience.